Okay, great. Well, thank you so much for attending today. It's really our pleasure to present this talk, this webinar series, Coccidioidomycosis, Clinical Considerations in the Aftermath of Wildfires, and then really what to look for, how to diagnose it, and how to treat. And this stemmed from several conversations really over the last several years. And then certainly the wildfires in Southern California this year have been a big concern. There's already been the concern that's been presented that there's been a big increase in Coxie cases down there following the wildfire. So we thought this was a very timely topic. Fareeb and I really are very pleased to present this. So just by way of introduction, I'm George Thompson. I'm a professor of medicine in internal medicine, Division of Infectious Disease at UC Davis here in Sacramento, California. And I'm joined by Fareeba Donovan, who's associate professor of medicine in the Department of Medicine, Division of Infectious Disease at the University of Arizona in Tucson. And we're really quite excited about this talk to go through really the sort of nuts and bolts of coccidioidomycosis, from sort of stuff done in the lab, research setting, all the way to the bedside, and then what's new. A few just very small housekeeping notes. We will have a pretty extensive question and answer period after Fareeba's talk. Just use raise your hand just like you're used to doing in Zoom. And this is recorded if you want to either refer to it later or stuff comes up that you maybe want to talk about or share with colleagues. And so let me share my screen and then we'll get started. Okay, so wildfire effects on the incidence of coccidioidomycosis is really where I'm going to start this talk. None of my disclosures really are applicable to the talk today, but to start really at a very broad and big picture setting, we're seeing more and more wildfires yearly than ever before. And of course, that's really a byproduct of our warming world. And the reasons for that are multifaceted, lots of overlap. There's political manifestations in that we're not going to talk about today. But there's been a clear increase just in the United States since the 1980s. You can see the map here at the top right. That's really a global phenomenon. You can see these wildfires really across the entire Earth. So we're going to really focus on the effects of wildfires sort of locally in Arizona, California, but this is really a global issue. So some of the things people don't know is there's sort of these climatic cycles that sort of have an ebb and flow to them, and that really began in the 1990s, but it appears to be substantially worse than what was predicted. Um, of course, the world continues to warm, but the biggest part of this is the fires we're experiencing are larger than they have been in the past. And the reasons for that are subject to lots and lots of debate. There's been changes in the management practice to prevent fires. There's clear funding issues with fire prevention. Regulatory issues can be part of this as well. So again, these are really multifaceted problems, but it doesn't get around the fact we're having more fires and larger fires than we've ever had before. And you can see kind of these graphs here at right that really illustrate that by millions of acres burned by US wildfires per year. And how does that relate to coccidioides? So before we get into that, I think just to review very quickly sort of the life cycle of coccidioides. And if you've got a board exam coming up, I want to just put some photos in there so you'll recognize these on your exams. But you can see this figure in the middle that has sort of a blue and green side to it. Down there at the bottom of the blue side, in the soil, coccidioides grows as this sort of mold phase, this mycelial phase. And you can see these are septate. This is vegetative mycelium. They form arthrospores or spores, but that really requires a period of drought or low precipitation. And with that, every other cell dies, and then the so-called disjunctor cells. And then we think that those little sort of broken leftover cells might act like wings and allow it to stay airborne longer. And you can see what that looks like by lactophenol cotton blue at left. And then again, white molds never open those up in the lab. There's too much concern for infection. But following these periods of drought or fire is going to cause some wind as well. Those are going to be stirred up, brought up into the air, and then breathed in. And then we're obviously at a higher temperature than the environment, and at that warmer temperature, different CO2 amounts, et cetera, that mold phase is going to convert to this yeast-like or spherular endospore phase. And you can see those in the top right. You can see those spherules are very large compared to your white blood cells, full of hundreds of endospores, and that can recapitulate its life cycle until broken either with an immune response, antifungal therapy, et cetera. And that's primarily just two species, Coccidioides immitis, Posidacea. There's probably 5 species of Coccidioides. It's not all been presented quite yet. And so you can see that this drought or low precipitation, which would be conditions, of course, favoring wildfires also, that's going to play a big role in spore formation, and that's the infectious particle. And if you look down here in the bottom of this graph, this is from sort of national data, but focused on California, you can see these time periods of very low precipitation. We had another one in the 1950s, and we're in one right now that's really been around since about um, uh, 2010 or so, and that's persisted. We've had sort of drought conditions throughout California, and we think has really paired up with why we're seeing so many cocci cases per year. So the epidemiology associated with that, these droughts again cause lots and lots of cases. And the textbook definition for epidemiology has always said there's 150,000 cases of cocci per year. More recently, the CDC has put in sort of a conglomeration of estimates, and this paper I think has been accepted for publication, but it really suggests that there's probably more in line with about 500,000 cases per year. A lot of those go unrecognized, or they have very sort of low-grade symptoms and don't come to clinical attention. But we do certainly know a lot of those have severe symptoms, end up in the hospital. We've seen more cases and more severe cases in Northern California just over the last year. And in the endemic region, sort of, Central Valley of California, around Phoenix, Tucson, about a fourth of all pneumonia is actually from coccidioides. So something to really remember, not to give just a second course or third course of antibiotics, but consider an endemic mycosis as really the cause of the patient's symptoms. You can see here sort of the state breakdown for California and Arizona. You can see that there's roughly 50-50. I think the last few years, it's California's had more cases, and the next year, Arizona's had more cases. So really, it just continues to grow with these changing climatic conditions. And then Morgan Goris had published this paper at Wright, looking at these different sort of soil characteristics that are needed for coccidioides to grow in the soil. And then what happens with sort of ongoing climate change scenarios under sort of a moderate scenario or high risk scenario. And you can see what that looks like here at Wright. Its cocci continues to move north and east. It's clearly not going to stop at the Canadian border. There's already cases in Mexico, of course. And I viewed this with a bit of skepticism when it came out. But I was called on an outbreak in Nebraska for non-travelers just about 2 years ago. So I think coccidioides is probably already there. It may be transiently endemic. It might blow up in sort of the warmer months and die off with freezes. I don't know. I don't think we have the answers to that. But I think cocci is clearly moving. It's clearly spreading for lots of reasons, but it's highly related to these overlapping risk factors with climate change that are also responsible for wildfires. So one of the things when you see that map is people often say, well, where do I live? What's my risk? Have I had coccidioides in the past? And even things like these giant dust storms that cover areas like Phoenix, these are called haboobs. You would think that they really just blanket the city in cocci, and they really don't. It's really more of an accumulated risk, ongoing exposure. But again, about 500,000 people a year contract cocci for the first time. Symptomatic infection in those regions is only about zero point 0.5 per 100 person years. Military recruits that are going to do things like sleep outside, lots of digging, et cetera, have lots of dust exposure, they seroconvert at a high rate, like 25 to 50%. But the public, even in high risk areas, Tucson, Phoenix, Bakersfield, et cetera, about 8% per year of life lived there. We have questioned if sort of the housing cost changes have increased those risks. And so what I mean by that is if you acquire coccidioides as a kid, you're much more likely to have acquired it asymptomatically. But if you moved maybe to the Central Valley or somewhere else where housing prices are a bit cheaper than, say, the coast of California, so you're non-immune, moving to a hyperendemic region, we think that might play a role sort of sociologically in why so many more people are contracting cocci per year. So all of these things are sort of tied together and be very difficult to tease apart. And then one more aspect, just really on the ecology of coccidioides, it really has this very complicated 2 to 2.5 year cycle for why it's in such high frequency in the soil. So it's not just temperature and precipitation patterns over a few months. It's really about a 2 year time frame. And you can see this from really nice work that Jennifer Head's done. She's now at the University of Michigan. But precipitation, again, really causes growth of coccidioides in the soil. It increases in frequency, in density at that time. And then droughts, again, enable dispersion with spore formation. And then these worsening drought conditions can lead to longer and more intense coccidioides seasons. And you can see graphically at the top, red is the temperature over time for really sort of about a year and a half to 2 year, 3 year period here, and then precipitation as well. And so the cases tend to follow about 2 years after this temperature precipitation cycle. So again, very intertwined with the risk factors for wildfires. And so here's one of the hypotheses. So you can see these different maps and they almost look inverse from one another. So the map of California, this is all of the California wildfires between 1898 and 2020. You can see basically they encircle the Central Valley of California and then sort of ignore Palm Springs and sort of Eastern California. But this figure in the middle, you can see that's really where all the coccidioides cases are. So how could those two things be related? Well, the working hypothesis is that not only drought causes cocci and drought causes fires, but to remember from sort of earth science in seventh grade, fire creates its own weather. And the way it does that is sort of that warm air at the bottom with burning vegetation rises up, so cooler air is going to rush in. But with that, it entrains air from a substantial distance around and can pull pathogens off the top of vegetative material, can pull off even the top bit of soil, throw that up into the air, and then allow dispersion. So we think that's one of the main ways that wildfire and coccidioides are intertwined. So with that, we've looked at this actually from the research setting. This is a paper I wrote with Lita Kobziar a number of years ago, really looking at this new field of pyroaerobiology, and that's that smoke does contain this living component. So, for a long time, it was thought, well, smoke's just too hot. Nothing can really survive that process of updrafts. But Lita and her lab at the University of Idaho fly drones over wildfire plumes of smoke, and they've found really a who's who list of opportunistic pathogens: Aspergillus, Mucorales, Cryptococcus, number of Candida species, a number of melanin-producing molds. So lots and lots of stuff is living in smoke. There's certainly bacteria there as well, but does leave sort of further credence toward this theory that fires might really play a role in pathogen spread and coccidioides as well. And so here's just an example of some of the work that Lita's lab does. You can see you can't fly drones over active wildfires. So they have to fly drones over prescribed burns that are to prevent larger wildfires in the future. And these are some of her graduate students. This is what one of the drones looks like, sort of in the middle here. It has culture media on there so that you can actually culture the air samples, and then they fly over these different wildfires with a sort of a drone army of sorts, and then identify all the fungal pathogens that are present after those things grow. And you can see how this really can cause a lot of problems. So certainly it can spread infections. Wildfire is highly associated with asthma. So are fungi. So this again really does lead to a lot of long-term problems and is an area of active and ongoing investigation that shows the confluence of fungi and wildfires. So what do we know about wildfires specifically causing outbreaks of coccidioides? And so something we've noticed a number of years ago, and the state of California has looked at this pretty extensively, looking at outbreaks of coccidioides amongst wildland firefighters. And these are reports from 2017, 2021. And a lot of the risk for these firefighters is exactly what you would see in this picture. They're not out there extinguishing the flames themselves, but they're building fire breaks, they're digging trenches. They're things where they're very heavily exposed to soil and sort of all of this sort of soot, et cetera, in the air. A lot of the firefighters, when you talk to them, you see them in clinic, it's too hot. They don't want to keep their protective gear on for sustained amounts of times. It protects them from dust, but we think it also protects them from coccidioides and other fungal pathogens. So it's been sort of difficult to try to do that. I certainly understand that. It's very hot to keep that kind of gear on, but we think this is playing a role in why they're getting so much coccidioides amongst the California firefighting service. And then here's a really nice paper that's out of UCSF that really showed this in a clinical way. It's the risk of fungal infections as a whole after exposure to wildfires. This is a retrospective study done just in California using administrative data, 22 different hospitals included in this. And any day with smoke in the prior month was associated with a 20% increase in risk in admissions for coccidioidomycosis. We have not yet found coccidioides in wildfire smoke. But again, we've really not sampled a lot of these naturally occurring wildfires. It's been solely prescribed burns, so that's sort of creates bias in that. But this sort of clinical paper really does show us there's an obvious association between wildfires and coccidioides acquisition. And then also you can see from some of these satellite images, the smoke that's produced by these large wildfires, it spreads across multiple different states. So if pathogens are carried up into the atmosphere by these wildfires, that might be a way that pathogens spread long distances. These ultrafine particles that are a byproduct of smoke and combustion cause epithelial injury. That's one of the ways that asthma is produced. We'll talk about that in a few more slides, but it leads to asthma, COPD, lung cancer. But certainly with epithelial injury, that's a major risk factor for acquisition of infectious particles. So we sort of joked around during COVID when it was smoky here that we called that smovid, but we did see cases of COVID increase with sort of smoke inhalation, and that since has been looked at in a paper that's ahead of print, not quite available yet, but there does seem to be association with smoke inhalation and COVID, just as there's been with other respiratory viruses, and certainly gives a lot more precedent for smoke, again, epithelial injury and acquisition of other infectious particles that are in the air. And so I mentioned asthma. This is a paper that this Caitlin Benedict with the CDC led this effort. So fungal pathogens have clearly been associated with asthma development. I think Aspergillus, Alternaria are sort of the classic pathogens for that. And the pathophysiology has been pretty well elucidated. We know which genes and which proteins made in Aspergillus and Alternaria cause asthma. They're the biggest risk factors. And there's orthologs for those same genes in Coccidioides. So it would make sense that Coccidioides could predispose to asthma. And anecdotally, we've seen that in a lot of our patients recovering from primary pulmonary cocci. Didn't have other complications, but they tend to have shortness of breath and asthma after resolution of all of their coccidioidal infection. So the CDC looked at this large database, 48 million patients in this database. There were over 6,000 with cocci. And then we wanted people who had a continued enrollment. We really could follow them long term. So about 1,600 patients in the total study population. And then what we really wanted to do was to see how many of these patients had a diagnosis of asthma or bronchodilator prescription use in the year after their cocci diagnosis. So we found it was actually substantial. About 13% of the patients with cocci had the diagnosis of asthma or a beta agonist inhaler prescribed after their initial diagnosis of cocci. To really compare that to other conditions, so it's about a 9% rate post-influenza, 11% post-Candida, which is not something we were expecting just to see. That may be a byproduct of just a big inflammatory milieu, post-Candida sepsis, et cetera. And then Aspergillus, it's known to be 20%. The highest risk of post-cocci asthma was seen in women. That odds ratio was 2.5. Severe infection with cocci also had a high odds ratio of 2.3, or those presenting with bronchitis, just as you would expect. We think cocci could either have unmasked underlying undiagnosed asthma, or it may have been causal. And you can see that the sort of causal mechanism with other fungal proteases and beta glucans has been well described. That's what's pictured here. And again, we think that's a pretty similar pathway to what might be happening with coccidioides. Again, that's largely a Th2 response. We know there's a fair amount of eosinophilia in coccidioidal infections, so it does make sense that this phenomenon might be there, but again shows some of the problems with wildfires, epithelial injury, certainly coccidioides. All of these manifestations can lead to long-term sequelae for these patients. So that kind of wraps up wildfires. There's lots of cataclysmic events associated with climate change. There's UV changes, there's drought, which we've talked about. Hurricanes certainly cause flooding, then mold's going to grow on drywall, et cetera, expose patients to that. There's some really nice work out of the Houston group, Demetrius's group with the CDC showing fungal infections post-hurricanes and flooding. Wildfires we've talked about. Water levels and salinity, not so much fungal, but certainly Vibrio and other pathogens are going to move in sort of their regions where they affect patients by changing water levels. But with this, and just to wrap up with a final slide on other aspects we don't really talk about much with climate change, but the agricultural effects, potential food insecurity, et cetera, really do place a larger demand for us to increase yields of crops. And with that, antifungals are put down in the environment really to try to suppress the amount of fungal infections on agricultural products. But the antifungals that are being put down can lead to resistance that later affects our patients. And the best examples of that are drug-resistant aspergillus in Europe, the Netherlands, and certainly in the UK. But with tebuconazole and other azoles used in the environment, they can lead to voriconazole-resistant aspergillus later. Well, in the US, just about a year ago, there was an approval for a drug called iflufeniquine to be used in the environment. And the problem with iflufeniquine is it works on the same pathway and same mechanism as alorifim. And alorifim, we've been very excited about for a while as a drug for patients with severe coccidioides. I mean, it's an oral drug. It kills the fungus very rapidly. So we're very excited for when that comes out. And if we use iflufeniquine in the environment, particularly things like on the almonds, which are in the Central Valley, we might be exposing coccidioides to high concentrations of this drug. They can adapt and become resistant before our patients have ever seen alorifim, and frankly, before it's even on the market. Very similar to that is aminopyrefin can cause resistance for phosphonogepics, another drug I think we're excited about, really need urgently in the clinical space. But I think the good news is sort of the governmental regulatory bodies have gotten together, the EPA, CDC, USDA, et cetera, and sort of approach this with a one health, one world view. Hey, we can't do stuff in the environment that's going to cause big human health effects later. And they've drafted a really nice model for this. And we're hoping that that's sort of picked up by global entities so that we don't do this just in a silo of the United States, but can work on this as sort of a global community. So I'll stop here and let Fariba talk sort of about the approach to treatment and diagnostics. But thanks so much for the invitation, and really my pleasure to talk through some of the aspects of wildfires and coccidioides.
Thank you, George. I appreciate the introduction, and thank you for having me today. This is a pleasure to be here with you. I'm trying to share my screen here with you. I hope everybody can see my screen. As Dr. Thompson mentioned, I will be talking mainly on the clinical aspect of coccidioidomycosis, considering that not everyone is familiar with the presentation, especially people who are on this call that are not from our area. No conflict of interest for this talk to disclose. And I had a couple of objectives. Epidemiology and expanding cocci burden is one thing that I very briefly mentioned. Dr. Thompson had a very nice coverage for this topic. And then we will talk about the valley fever clinical presentation and the main challenges that are involved with the diagnosis and the treatment of the disease. And then talking about the management of patients when they have, especially those that have severe disease, how do we approach them? So as Dr. Thompson mentioned, this is a soil fungus. There are two strains that now we are talking about. However, there are other strains that hopefully will be more identified, Emitis and Posodacea. Other names for the disease, Coccidioidomycosis or Cocci in brief. I'll talk about why we chose that abbreviation. And then as again, Dr. Thompson mentioned, originally the estimate was always mentioned in all papers, 150,000, but new studies by CDC shows that it's much higher actually than what we always thought about. And the important information here is that it can be caused with inhalation of one spore. So really important to know the disease. The good news about that is we usually have about 60% of people who potentially had it, got exposed to it. They don't even know they had it. It's subclinical. About 30% of them develop this pulmonary picture like flu-like symptoms, community-acquired pneumonia. And about 10% people get complicated, either pulmonary or a subclass of those group, 1 to 3% develop severe disseminated disease. This slide is kind of an eye-opener because the impact that has been reported to be annually is more than $1.5 billion. So we really are dealing with a disease that has major impact on human health and their well-being. The worst case scenarios are usually for people who are at higher risk. As you see here, people who are older, certain ethnicity groups, African Americans, Filipinos are considered to be at higher risk. Of course, pregnancy always gives a higher risk of infection, and people who are immunocompromised. And this could be people who are on chemotherapy agents, people who have transplanted organs, bone marrow transplant patients, or nowadays we see a lot of people who are on biologic response modifiers of any category that could put the patient at higher risk. Now, interesting to see this, that the the effect of it on human being is similar to what polio was, chickenpox, or measles before the vaccine were discovered and used. Now, usually after infection, people develop lifelong immunity for a second infection. And that actually gives us a very good idea about, well, if we develop and we are in the process of developing a vaccine, that would be a good choice for this disease. So the first question I have here is, which part of the world do you think is most endemic region? I know that you just saw that in Dr. Thompson's slides, but just go for it. Is it Midwest, Arizona, California, and or Mexico? I'm gonna let you answer the question. I'm going to cheat and give you the answer after you answer the question. So yes, you're right. Arizona and California both, but Arizona still is higher than California. Thank you for responding to this. So let's see if I can. Okay, so this is a map of Arizona, and we call this Valley Fever Corridor between Phoenix and Tucson is about 2/3 of all cases of the country happening and being identified. Dr. Thompson had a great slide on this. The mycelium mold form of this grows in this area, desert soil. And once it gets mature, these arthroconadias or spores get broken down and get airborne. And of course, when we inhale them, they get seeded in the lung, and it could go to the parasitic phase, which is this phase, and one spore can become a very large spherule with 300 endospores. They get mature, they break down, and the cycle goes on. The area that recently CDC actually updated in the map of the country is that really the whole part of western part of the country is becoming endemic for this disease. Mainly it was California and Arizona, but you see that it's expanding. So I have here for you travel history. So for those of you who are in this call that may not be in the endemic region, really that's very important to ask people, especially with our global life now. We all travel everywhere. So when somebody comes in with this presentation, just a simple question of, have you been to Arizona, California, Nevada, any of these areas might be a big help in identifying the disease early on. And of course, I have a map of the world that shows even Central or South America has some areas that has the disease, higher burden of the disease. So a simple travel history question may become very handy. Just again, repeating of the same thing, that it is endemic in Arizona and California more than anywhere else. And over time, you see that the number of cases in both states have gone up. This is our desert, very beautiful desert. When you go and hike, the arthroconidea could get into your lung, and then you see that patients develop this area of lobar pneumonia. And if they have nodules and they have had history of smoking, they may go through biopsy, and when this nice spherule is seen in the tissue is when patients are sent to us. So keep that in mind. This is an interesting and eye-opening study that we have done, the delay of the valley fever diagnosis. And I'm not talking about non-endemic region. This is in Tucson, Arizona. When we looked at these people who go to the urgent care, that's usually where people go first before they go to their primary care physicians or our offices, even you see that even the disseminated cases here, we have documented that there are 43% of these diagnoses have more than a month of delay. And that comes with a lot of antibiotic use, a lot of, fear, anxiety in patient side, a lot of unnecessary tests that is done to identify a disease that could be identified much faster and much sooner. So for that, we usually use this tutorial. By the way, this is on our website, Valley Fever Center for Excellence. You can access that. In this tutorial, we talk about what is the disease, the pathophysiology, how to diagnose it, what are the tests to do, and when to treat it. So please feel free to log into our website and look at it. In this tutorial, we use that mnemonic that I mentioned earlier for Cocci. Consider the diagnosis, order the right test, check for the risk factors, check for the complication, and then initiate the right management for the patient population you're dealing with. So now the second question is, what do you think about this? What is the most common presentation of the disease? Pneumonia, rash, fatigue, joint pain, or all of the above? Great, we have a good breakdown of people's opinion. Okay, let me see here. So the most common presentation is really all of the above. Any of these could be the presentation. And here I have this primary coccineumonia. It's really similar to community-acquired pneumonia. You see here, there is a lower presentation of the disease. In chest x-ray, people have fever, night sweat, cough, chills, joint pain, pleuritic chest pain, the fatigue, which is one of the hallmarks of the disease, extreme fatigue, very long-standing, and then headaches. So any of these come in, you should suspect that, especially in our area. And as Dr. Thompson earlier mentioned, 1/3 to 1/4 of our patients that come with quote-unquote community-acquired pneumonia diagnosis end up being valley fever. So keep that in mind. The other presentation is this erythema nodosa, macular rash, upper or lower extremities, and they are tender. And for these patients, they usually are sent to their dermatologist. They go there, and then they are sent to our office for evaluation. And in this case, people have usually eosinophilia. So I have a couple of pictures here, clinical pictures of fibrocavitary cocci. It could be a single thin wall cavity. Sometimes they are so small that people don't even know unless they get a chest x-ray for other reasons. Sometimes they become very complex, like this case with chest pain, shortness of breath, dyspnea on exertion. Hemoptysis is one of the hallmarks that they bring them in. How do we diagnose this disease? Well, the most definitive diagnosis is culture, but please make sure if you think about the disease and you ask somebody to culture it for you, if it is a sputum or if it is BAL, make sure that you give the lab a little warning about Cocci is in your differential diagnosis, because this is a biosafety level 3 and it's a laboratory hazard, so they take a special precaution for your sample. The other thing is in histopathology, the characteristics of the empty sphereole, the full sphereole, or the rupturing sphereole helps us with the diagnosis. The other diagnostics are serologies, immunodiffusion complement fixation, as it is noted by Dr. Thompson's publication. It's there to establish the diagnosis. It could be negative and early, or in patients who have some level of immunocompromised state. In disseminated cases, it could go up, very high titers. And if we check the CSF and it's positive, any positive CSF is positive, so no question there. For the screening, we use enzyme immunoassay, EIA test, that has its own issues. We have potential false positives, good sensitivity, but it could have cross-reactivity with other endemic mycosis, such as histoplasma. And then another test that was developed by EMI, I actually used it here. It's a very good rapid test. It's a lateral flow assay. You take the blood, you use the serum, you dip it, and in 30 minutes, with a couple of steps, very simple, you can see if the line is visible or not. The problem is that it's good specific test, but sensitivity was not as high. So I think that test is a good test if you combine that with, say, other confirmatory tests to make sure you're not missing any cases. So the next question comes, does the valley fever affect the immunocompetent host? Perfect. Everybody knows the answer. So yes, you're right. It does affect. And one example of it that we have, okay, sorry, was the former Arizona Wildcat linebacker, Sterling Lewis, who died at age 32 from valley fever. So this is really the important thing that we have to emphasize in the community. Somebody who comes to you and the presentation somewhat is questionable for you, is it valley fever or not? Because they are immunocompetent, don't disregard the potential for people who develop the severe illness. So going through the risk factors based upon IDSA guideline, people who are immunocompromised, of course, diabetes, people who have severe cardiovascular disease, pregnancy, and the certain ethnicities such as African Americans and Filipinos in our area. If somebody comes in with this quote unquote community acquired pneumonia and having that specific ethnicity, I will really make sure that I ask all the questions to make sure I don't miss that case potentially becoming severe disease. And of course, if they have severe primary infection, that could become a problem later on during the course of the disease. So how about if it goes beyond lung? Most complications that happens as disseminated disease happens in the very early stages of the disease, first few weeks to months. About 5 to 10% of cases could develop these severe pulmonary sequelae, and about 1 to 3% of patients could develop disseminated disease. And you ask, oh, where does it disseminate? Really anywhere. Could be skin, could be bone, brain, or any part of the body. This is a patient we had that had a synovial quote unquote abscess. It was drained and it was positive for valley fever spherules. So next one is, how long do you think we should treat coccimeningitis? Great. 67% of people were right. So about half of the patients who have disseminated infection, they develop chronic meningitis. And to confirm this, because you're committing somebody to lifelong treatment, you better get a lumbar puncture CSF testing to confirm that. And any positive serology in CSF is considered positive. And of course, the disease was 100% with mortality rate. And after introduction of fluconazole in the market, it came down to 30%. It's still too much, but much better than what it was. And as you just saw, treatment of meningitis is considered lifelong. So I have a couple of diagrams here for you for treatment, and these are based upon IDSA guideline and recent publication we had on the cavitary cocci treatment and recommendation. So if somebody has uncomplicated cocci pneumonia, that's the community-acquired pneumonia, do you really need to do antifungal? Really, at this point, if patient is immunocompetent and has no other risk factors, you give them a good education about pathophysiology, maybe go through the tutorial with them if they are in the medical field, monitor them, bring them back a few times to make sure there's no other area of involvement, and give them reassurance and supportive care. Remember, when I told you that they have extreme fatigue, that's where patients, when they come to us, they complain of this severe fatigue. And what the best approach to that is not really antifungal treatment, is reconditioning exercises and reconditioning maybe physical therapy for them. Next group are those people who have cavity, but they are asymptomatic. And in this case, as you will see in our other paper just recently published, really, again, you do the same approach. If they don't have any symptoms with a small cavity, we just monitor them. Now, if they have a cavity and they have symptoms, means they're short of breath, they have hemoptysis, any kind of symptoms, in addition to those, you consider treating them with what is mentioned in the guideline is fluconazole, itraconazole. Obviously, we have other choices now that we could use. And in this stage, I usually get a thoracic surgery consultation to see the patient, and not necessarily to do the surgery, but at least if in case needed, they know the patient. For the next group, people who have disseminated disease as in the soft tissue, that again, one of the azoles, whichever one that you like to use in combination, maybe with amphotericin for some period of time. These are for people that they add amphotericin, or people who have like maybe paraspinal abscesses, psoas abscess, something that perhaps needs a combination regimen for a while. And then if they have a spinal vertebral osteomyelitis, I always get a spine surgeon to see the patient. They may not elect to do any procedure, but at least they know the patient. And then again, azoles in combination with ampho or alone. And then if you suspect coccymeningitis, always consider doing a lumbar puncture, confirm the diagnosis. And in here, I wrote high-dose fluconazole because that's what is recommended for meningitis. Sometimes you need to do combination with amphotericin. And here again, the surgeons are involved to evaluate the patient. If they have hydrocephalus, sometimes they need VP shunt. So I said high dose. What are the toxicities that come with it? Well, of course, in fluconazole, alopecia, cheilitis, dry skin, QT interval issues. And in a study that Dr. Thompson again was involved, evaluation of more than 300 patients on fluconazole more than 30 days showed that people, 50% of them stopped it after 30 days because of these toxicities. For posa and itraconazole, you see that renin-aldosterone could get affected. They have elevated deoxycortisol, and they may develop hypokalemia, hypertension. So you want to make sure that these electrolytes and blood pressure are being monitored closely. The other one is voriconazole. You all are familiar with CNS peripheral neuropathy, hepatotoxicity, photopsia, or photosensitivity. And especially in our area, cutaneous malignancies is a major issue because of the sun exposure and fluoride toxicities that may happen. And then, of course, amphotericin that we use, especially for more severe cases, you know, the potential problems with it, nephrotoxicity, anemia, fever, the reactions that during infusion happens. So the very last part of my talk, I'll be talking about the unmet needs. What do we really have right now in our hand is several azoles. They are all fungistatic. So what is the best option for this disease is having a fungicidal agent, has good CNS penetration for a meningitis patient, has lesser toxicities, so a patient can tolerate it longer. And maybe because they are cidal, maybe we don't need to use it for a long time. And thereby patient has better quality of life. All things considered, there are a couple of agents in the market. Olorofim is one of them, oxoconazole, nicomycin. Some of these are on clinical trial, like olorofim is, and oxytoconazole that we are trying to see if we can use it for cocci patient, although the FDA approval is not for cocci indication at this time. So to that end, this is the last slide. And thank you for being here. I'm happy to answer any of your questions. You see my email here. I'll be happy to get any emails from you and help you if you have any case of questions.
Yeah, thanks, Fariba. That was fantastic. Appreciate all of the updates in diagnostics and treatment of coccidioides. We're going to open it up for questions. If anyone has comments or questions, we are happy to discuss those and see how we can help.
And folks can use the chat box to ask a question, or they can use the raise your hand icon, which is found in the reaction icon, usually at the bottom of your.
And I see that Carolyn has our Valley Fever website on the chat. If anybody needs that, please. Thank you.
So is there a good PCR test? Fariba, do you want to start with that one?
Yes, there is for specific samples. We use it for bronchoscopy, BAL. And actually, I was talking to one of our intervention pulmonologists here who is developing a test, a PCR test for cocci when he goes into nodules robotically to take a sample and then actually increase the yield of the result by having a specific sampling of that. PCR is available, but the samples that we use are specific.
And then Friba, do you all use the PC? I know Fresno uses the commercially available PCR on BAL samples. Do you all use that one there?
Yes, yes.
You all do?
Yes.
It's the same one? Okay. Yeah, we don't routinely use that one. I think it's just because we're a little too far north. We're not right in the endemic region. We
Yeah.
tend to just get the bad cases sent to us instead
Yeah.
of the but yeah,
We
that's a great question,
actually,
David.
a lot of our cases that go to our nodule clinic in cancer center, if they see something that they need to do bronchoscopy or get a biopsy, a lot of times they use that PCR for those samples.
Okay, Denise McCulloch, how do you take into account cocci when evaluating non-specific fungal nodules in patients who are pre-transplant? Yeah, that's a fantastic question.
Yes.
I think maybe we can both. I think our answers are gonna be different. So Friba, if you want to go first, I'll
Okay.
say something after.
So this is a fantastic question. The push and pull that we have with our pulmonology and transplant services. So because we are endemic, actually there are a lot of people that have nodules. So the question that we ask them is, do you really have to biopsy all of these? But you know, somebody doesn't have any past history of smoking and has lived here all their lives. Now they are getting an X-ray or a CT and there is a nodule. You know, I think it's above 80% of cases that the nodule is biopsied here is cocci. But by the time they get to me, the biopsy has been done. The result has been concluded as a spherical, and now they are in my clinic. So should we say not to do it? I can't tell you that.
Yeah, I think our approach, just not being in a hyper endemic region, is, again, these are all pre-test probability things. So we really take into account where the patient lives. If they're kind of
Right.
north of Sacramento, we think that they have a really reduced risk of that being coccidioides. If they're from south of Sacramento, sort of Stockton, Lodi, et cetera, that's in the heart of the valley. So we
Yeah.
probably treat them a little bit more in line with what you all do. But it's a great question. I mean, I think that, we're hopeful advances in imaging technology are going to solve a lot of these issues going forward. That's a different talk. That's a very long answer that I don't want to belabor today.
Yeah.
But it's a challenge. Diagnostics can't always tell is this that they have valley fever, but now they have lung cancer. PATH's still sort of the answer for those patients. But we're getting a bunch more questions. So I'll go through the next one here. False positives possible. Short answer is, of course, yes. I think that's most prone with EIA IgMs. I think those are the most problematic as far as causes of false positive tests, just like most IgM testing, even for other diseases. So that's definitely something to consider. And the CDC has a really nice diagnostic algorithm they just published late last year for the approach for diagnostics for all of the endemic pathogens or not all, but the US specific ones. So cocci, histo, and blasto. So that's a nice reference that I might point you towards. And then Tom Schmidt, how have farming communities responded to discussions about reducing use of antifungals in similar classes to upcoming drugs like olorifim? Have they been receptive? So the short answer is yes, they have. I have a lot of friends that are farmers here, and I say, what antifungals do you put down? And they say, I don't know, the one in a white jug. So I've sort of enjoyed that, but I've been a consultant for the state almond board, and they actually were pretty intrigued by this. They want to protect their farmers and farm workers. They have a high incidence of coccidioides in that setting. So they are very interested in this as a problem. They are receptive as long as they have an alternative. I mean, I get it. They're worried about their bottom line, so they've got to figure out how to maintain a good crop production but still protect their workers. But again, I think the EPA, CDC, USDA have been really, really forthcoming to try to come together instead of have a siloed approach to care in the environment. So I'm actually very pleased with what the federal agencies have done. I think it's been fantastic. And then, Freeman, I don't want to keep talking, so I'll give you the next one. What's your sense of the test performance of cocci serologies in patients on B-cell depletion lymphoma patients?
Right. This is patients who are on rituximab, one of the agents. And we don't see, I mean, a lot of patients, I have to give you a little epidemiology introduction. In our environment in Arizona, we have a lot of older patients who are on a lot of these biologic agents. And amongst those are B-cell inhibitors. And I would say that I always expected to see more of cocci patients coming on these agents, and I don't. However, we are actually, studies going on in our lab right now that showing that, you know, when you see the granuloma in animal, in mouse lung, and you give them the B-cell inhibitors, the formation of these granulomas change. And it looks like the spherules start dispersing from that nice dense granuloma. So the studies are ongoing. As of a short answer is that it doesn't look like it's the same as, say, TNF inhibition, but we still have to wait and make sure that we have the data, more scientific basis for this.
Mm-hmm. And can you share clinical experience with the plasma next-gen sequencing test Socarius to assist in diagnosis in patients who can't undergo invasive procedures? I don't think that's been looked at systematically. There was a poster presented with Carius, I don't know, 4 or 5 years ago at one of the Cocci study groups, and I know there's been at least one publication on that. I think Carius, I mean, it's expensive, but it does have a role for some patients, particularly in mycology as a whole. I haven't really needed that much for Cocci specifically. It seems we can make the diagnosis some other ways. I get, though, that if you want to avoid invasive procedures, but I don't think in the vast majority of people with Cocci, they don't tend to have a lot of antigenemia or DNA-emia. They can, but most of these patients, again, with Cocci are immunocompetent. And neutrophils are pretty good at scavenging antigen and DNA. So, you know, the short version is I don't know because we don't have a big comparative study. But we have not used it much. Fariba, have you all?
We don't use it as much either. Only a specific population, like the bone marrow transplant patients, that really all the studies already done and they can't do biopsy because a platelet is low. Sometimes they use this. It's a send out test. It takes a long time to come back. It's very expensive. So very specific situations we use it.
Yeah, we've had fair luck. You know, about a fourth of our patients that have had Carius sent, we've gotten a result back. But I mean, not Cocci. These are Mucorales, Aspergillus, some other things. But yeah, future work hopefully will help us with that. How do you approach Cocci prophylaxis and solid organ transplant patients who only have a positive IgG, but negative COMP-FIX and immunodiffusion?
So in our center, we have a lot of solid organ transplantation going on. What we usually do, we screen the patients prior to transplantation. And any positive test is considered positive. And, you know, if any test is positive, we usually put them prior to the transplantation on antifungal prophylaxis, and that stays for a year. Now, if the test is negative, they still, because they live here, they go on prophylaxis, but then the duration is about 2 to 3 months until they are all back to their normal life, and then we can monitor them. But generally speaking, would be at least a year of prophylaxis if any test is positive.
And then I think this will be our last question. As a city and fire department that interfaces directly with the Eaton wildfire, is there anything we need to communicate to our residents or firefighters regarding concerns or preventive measures to take regarding Cocci? Is LA County Department of Health Services putting out any guidelines? Yeah, that's a fantastic question. So again, we don't have much evidence. I mean, our short version is particulate matter as a whole is not good to inhale. So we usually just tell patients if there's wildfires, you know, you can look up the air quality index online for your particular region. And if it's high, just don't go outside. And if you do, you know, for Cocci protection, you really need an N95 mask. by the size of the spores, not just a cloth or something like that. So I don't think that's a bad idea when particulate matter is high in the air anyway. You know, people with asthma, immunocompromised people want to avoid those things. They're going to avoid Cocci as well. And then I have not seen any LA County guidance. I'm sure they're putting some together. They've been very proactive. I think the message would really be, if you've got respiratory symptoms, consider being tested for Cocci. I mean, I think that would be just sort of the bottom line for that. I guess we'll do one more question. So sorry to add one more late at the buzzer. But people who are Black or Filipino heritage are at risk of developing disseminated Cocci, but do you expect they will have a different treatment response to the drug? So Freeber, I know this has been a huge effort.
This is a great question. It comes back to what is that genetic predisposition to make them more developing the more severe form of the disease, and if that genetic predisposition make them less or more responsive to the medication. We have some gene candidates that we know it's prominent in this population. Is that affecting the response to drug? I don't know. Maybe to some extent. Anecdotally, though, in clinical practice, I don't see the difference in the response, but I definitely see a difference in the level of and the risk of the disease. You know, just a simple example of it, based upon what we have published, we know that in Arizona, the African-American population is about 4%, but in a study we did, actually the cases, African-Americans with disseminated disease had 12% of our population in our study. So definitely there is an increased risk, but to the drug, I don't think. Do you, George, know if there's any difference in the response to antifungals?
I don't think that there's a difference in response that's been teased out. I mean, the genetic polymorphisms do cluster a bit by those of oceanic genomic ancestry, because we've always sort of just said Filipino, but it's, you know, we have Marshall Island patients, et cetera. So it's really a lot of Oceania, and the genetics of Oceania is actually very complex from talking to the folks that do that work. But the genetic polymorphisms do cluster, and the primary three that have been described are Dectin-1, PCLG2, and DUOX1. And we do think that sort of the clinical forms of disease might cluster by those polymorphisms, but still, even finding out those three different polymorphisms only explains about 50% of the disseminated infections. So there's still a lot of genetic work to do. And I think we're going to have that sorted out probably over the next 4 to 5 years. Just, I mean, the Cocci community has really come together to try to recruit very large data sets to answer some of these old questions. And then just a comment. So it looks like LA County does have health education material that was sent out to all the firefighters and EMS agencies, which is great. I had heard that. I certainly haven't seen it, but I don't need to since I'm not down there. They wouldn't need my input. It looks like they're planning a webinar as well. So that's encouraging to hear. I knew they'd been very proactive about this, so that's fantastic. I think we'll stop here. We're really at the end of the hour. Fariba, thanks so much for all your input today. It's always a pleasure to give talks with you and just see you again.
Thank you.
And then thanks so
me.
much for all of our attendees. You know, we're always available by email if anyone needs anything. But for the rest of your day.
Thank you.